Bismillahirrahmanirrahim. Let's see the management of labor. As we discuss the normal labor by stages. Stage 1, where the effacement and dilation occur, and stage 2, where the delivery of fetus is occur, and the stage 3, where placenta delivery occur, and the fourth stage, which is the 2 or postpartum, the observation. So we also look at the management by stage wise. So some initial assessment of normal labor, of course, full history. I mean, you take the complete of the history, and especially the ask about the parity and the previous delivery. Okay, and the history of the present pregnancy and the present labor, labor pain, vaginal bleeding, gush of blood, and the fetal movement. So these are all the present labor presentations, so we need to assess all these. Okay, and in the examination, in the general examination, in vital sign, the pulse, the blood pressure, temperature, the anxiety, dehydration, pallor, and edema. So these are important because it help us the how the patient is treating throughout the labor with the doctors and the nurses. Okay, so anxiety, dehydration, pallor, edema. Abdominal examination, start with the inspection of the abdomen. I mean, it's convex from all sides. Okay, and the palpation through the Leopold maneuver, where we assess the fundal level presentation and the position of the fetus. Okay, and the auscultation, I mean the fetal heart sound below the level of umbilicus to one side of the midline. So here is the Leopold maneuver. So there are 4 steps. So the first step, we assess what fetal part is present in the fundus. Okay, and palpate the back of the fetus. Okay, and palpate the engagement of the presenting part. And the fourth is the palpation of the position of head, and they assess the descent and the flexion of the fetus. Okay. Here are some common site for the auscultation of the fetal heart sound. Okay, so this is the left occipital anterior position to auscultate the fetal heart sound. Here you can see the electronic fetal monitoring vaccinal technique. So where you can see the tocodynamometer, so which is for the uterine contraction, and here is the ultrasound is placed, or here you can see the display of the fetal heart sound. So the ultrasound device is placed over the back of the fetus. Okay. And then the vaginal examination, it's contraindicated if there is active or the history of the vaginal bleeding. So if there is no active bleeding and no history of vaginal bleeding, we should do the vaginal examination. So where we check the Bishop score related to cervix. Okay, and they assess the membrane. So it's if intact or the ruptured. If ruptured, exclude the cord prolapse. Okay, then check the amniotic fluid after the rupture membrane. It is clear. Either it's a meconium stain or blood stain. Okay. So and assess the presenting part, the position and the station and the molding and the caput of the fetus. Okay, and assessment of the pelvic cavity. So and the investigation. So it's if recently available, it's good. If not available, you should do the blood group and the RH type and the HB level and the urinal analysis for albumin and the sugar. Okay. So this is the history and examination and investigation related to the initial step toward the normal labor. Now we move forward to the management of the labor stages. In the management of first stage of labor, you should remember the mnemonic anaerobes. They represent the asepsis and antisepsis. So you should shave the vulva and clean the vulva and apply the antiseptic solution, and represent the nutrition. So in the early latent phase, you should give the oral surgery fluid, and in the active phase, give 5% glucose solution. Okay. A represent the analgesia and sedation. So the better choice is the pethidine, and then the morphine, or you can give the epidural or the low supinal anesthesia. Okay. And evacuation of the bladder and rectum, bladder by macerating every 2 to 3 years by catheter. Okay, And then evacuation of the bladder and rectum, bladder by maturating 2 to 3 hours or via the catheter. So you should empty the bladder, okay, and the rectum by giving the enema, and you should reduce the pervaginal examination at least two means start of labor and after the rupture membrane, okay. And observation, mother observation for the blood pressure, pulse, and the temperature, and fetus heart rate intermittent or continuous, and the partogram, which is the part of the active management of labor, okay. What about the bearing down or straining? So it should be prevented because it's a useless and it's exhausts the lady, okay. And the last S, which represent the position. So if if intact membrane allow walking, if the membranes are ruptured, so rest in the left lateral position, okay. So this is the management of first stage of labor. Just remember the mnemonic and arrows, okay. Now move to the management of second stage of labor. Mnemonic is DSP, scared from wife. Okay, so start with the D. You should shift the patient toward the delivery room. Okay, and the position in the delivery room should be the lithotomy position. So this is the lithotomy position, and antiseptic solution on the vulva and the perineum, and sterile legging and the towel should be applied. Okay, and allow the straining during uterine contraction and relax in between. So the straining should be with the contraction, and the mother should relax in between the contractions. Okay, and perineal support by sterile dressing, and allow the extension after crowning and modified retention maneuver. Okay, and episiotomy if needed. Okay, as I already mentioned, so this is the second stage where you can see delivery of baby and crowning. Okay, so allow the extension after crowning. Okay. So here is the maneuver. We apply pressure on the chin, which is upward, and the backward. Okay, and the downward pressure from the occiput. So this allow the gradual extension of the head. So this prevent from the perineal tear. Okay. So here is the delivery of head, and here is the delivery of shoulder. Here you can also see the crowning, and we are applying pressure on the chin to prevent the perineal tear. Okay, and here you can see now we are delivering the fetal head. Episiotomy if needed. So there are two ways, either midline or the mediolateral. So it's also prevent from the perineal tear. Okay, so but the midline has a risk. You may reach the anus and rupture the anal sphincter. Okay, so mediolateral is a better choice as compared to the midline. Okay, after the delivery of a head, you should swab the nose and the mouth, and then look at the loop of cord. If it's around the neck, try to slip it. So if there are several loops, you should cut the cord in between. Okay, so you apply two clamp and cut in between by the scissor. Okay, and then you deliver the interior shoulder and followed by the posterior shoulder. Okay, and the rest of body deliver easily. Okay, and hold the fetus via feet, but it's contraindicated if it's a premature or fetal asphyxia or a suspected case of the intracranial hemorrhage. Okay, and the last step is the umbilical cord milking toward the fetal umbilicus to add 100 cc of blood to the fetal circulation. Okay, so it should be avoided in preterm or if case of RH incompatibility. In this picture, you can see the four different action toward the umbilical cord. Okay, so this is a early cord clamp. So here the delayed cord clamp. We are clamping the cord more than 60 seconds. So here is the way of the delayed cord clamping. So you can see level of the baby is lower than the level of the uterine. Okay, so that's why blood is coming toward the baby, so which provide the circulatory stability. So this decrease the need for the resuscitation, and decrease the interventricular hemorrhage, and decrease the mortality. Okay, so it is a better choice as compared to early cord clamping. So early cord clamping is indicated if there is RH incompatibility and asphyxia or premature baby infectious or the diabetic mother and the C-section case. So in this way we go for the early cord clamping, otherwise the delay cord clamping is the indicated. Okay, The other way is intact umbilical cord milking and the cut cord umbilical cord milking. Okay, so in the intact, we are not separating the placenta from the umbilical cord. Okay, so here you can see we have clamped the placenta. So just umbilical cord is here. So intact cord is more beneficial as compared to the cut cord umbilical cord milking. So in umbilical cord milking, what we do, we externally transfuse the 100 cc of blood to the baby, so this help the baby, so circulatory stability and also potential therapeutic effect, like in case of the intraventricular hemorrhage, the periventricular leukomalacia, epileptic encephalopathy, stroke, the retinopathy of prematurity, cataract. So a lot of other beneficial point toward the umbilical cord milking. Okay, so this is the management of second stage of labor. DSP scared from, so the delivery room shift as the training, the perineal support as a swab, C represent cord, A interior and posterior shoulder, R represent the rest of body. Okay, and the other is the F, which represent the feet, and M represent the milking. So this is the second stage of labor. We should also inspect the lower genital tract and the perineum for the laceration and tear. So if there is a laceration and tear, it should be repaired. Okay. So if you look at the perineal tear, so there are four degree: first degree, second degree, third degree, and fourth. In the first degree, only the skin is ruptured, and the second degree skin and muscle, and the third degree anal sphincter is also involved, and in the fourth degree, so rectum is ruptured. Okay, here you can see the first degree only skin is involved. Here muscle is also teared. Okay, and here the anal sphincter reaches, and here you can see the tear of the rectum. Okay, so and the midline episiotomy has also risk of the rupture of the anal sphincter. Okay, so that's why the mediolateral episiotomy is preferred. Okay, so this is the midline. So you can see it can reach to the anal sphincter. Now look at the management of third stage of labor. So there are two ways of managing. One is the conservative method, other is the active method. In the conservative method, we just put our hand over the fundus lever, okay, and wait for. We are not applying pressure here. We are just, our hand is here, okay. So and wait for the sign of the separation. So what are sign of separation? So as I already mentioned in the third stage of labor, so elongation of cord, okay, and the gush of blood, and the third is the suprapubic bulge. Okay, so these are the common sign. Okay, then we take out the placenta and assess the all its component and the membranes. Okay, so this is the text. Put a hand on fundus and wait for the sign of the placental separation. Then encourage to strain and catch placenta and roll between the hands to peel away the membrane and examine the placenta. Okay. Here are some other signs of separation of the placenta. One is the Rathbone sign, means the stoppage of the pulsation in the stump. Okay. Other is Startsman sign, which confirm the placenta is attached. Mean when you gently impact on the fundus, so this is transmitted as a wave to the umbilical cord. Okay, so if it's attached, so this wave will be observed over the umbilical cord. So this is confirm that placenta is still attached. So other is the cord elongation. So if there is no cord elongation, mean the placenta is not separated. Okay. And after the delivery of placenta, you should give ergometrine and the centocyane. One other point you should remember: do not massage the uterus until placenta separation sign appears. Okay, wait for the placental separation sign, then you can massage the uterus. Okay. So this was the conservative method. Now look at the active method, which is the control cord traction. Okay, so we are pulling the placenta. Okay, so we give the methergine. We give the methergine IV with the delivery of head or the interior shoulder, and then we can apply the modified brand induced method. What is the brand induced method? So we apply the pressure on the lower abdomen and gently push the interior surface of the uterus, okay, and toward the patient umbilicus. And after the placenta separation, so we press the fundus downward, okay, and take the placenta out. Okay, so here you can also see we are just pushing the interior border of the uterus, okay, to separate the placenta. after the separation of the placenta, we press the fundus downward to deliver the placenta. Okay, so other is a Credos method, which is somehow painful and lead to uterine eversion or prolapse. Okay, so what we do in the Credos method? This we applying the fundal pressure. So by gripping the fundus in between our the thumb and the fingers and try to squeeze. So in this way we separate the placenta. Okay, and also deliver the placenta. Okay, so this is the reduce method. We just squeeze the fundus. Okay, so here you can also see we're squeezing the fundus. Here are four fingers. So here is our thumb. Okay, so and push the fundus upward gently by ulnar side of left hand to deliver the placenta. Okay, so this is the management of the third stage of labor. Management of fourth stage of labor, which is 2 hour observation after the placenta delivery. So for the detection of the postpartum hemorrhage. So what is postpartum hemorrhage? When there is more than 500 cc blood is lost, okay, in the vaginal delivery. So this is considered the postpartum hemorrhage. Okay, and here you can see. So if there too much blood is lost, so this is a postpartum hemorrhage. And neonatal care, which is the job of the pediatrician. Okay, so the our management, and over here we are assessing the postpartum hemorrhage and the neonatal care, which is job of the pediatrician. So what we do in the pediatrician do, so I'm just putting a context. It's your choice to remember or not. Okay, mnemonic is the breast past. So P represents the position. Put the neonate on rigid flat table under the radiant heat from above. Okay, and clear the respiratory tract, head low down, 15-degree resection to remove the mucus. Okay, A represent the Apgar score, which should be done at 1 minute and 5 minutes. Okay, and the care of the umbilical stump, ST stump. Okay, and so in case of the sepsis, you can see so inflamed stump. So clamping and the alcohol should be applied. Okay, and the examination for the sex and the congenital anomalies. Okay, A and S. Okay, the anomalies and the sex. And B represent the bathing, to clean the neonate from blood, and vernix schizosa, which is the thick white substance composed of the sebum and the desquamated epithelial cells. Okay, and the care of eyes, give antibiotic or antiseptic eye drops to avoid the ophthalmoplegia. Okay, which is the neonatal conjunctivitis. Okay, so give antibiotic or antiseptic eye drops. Okay, and B represent the body weight of the baby. Okay, and last is the dress and mark the baby. Okay, so this is fourth stage of management. So here is the simplified version of the management of the labor. Okay, so you can read on your own self. So this is all about the management of the labor. Thank you very much. Allah Hafiz.